All right. So we're going to go ahead and get started. I'm going to go ahead and share my screen with you guys. I'm Katie, Catherine Hoffman. I'm joined by Amanda, who's the other dietitian here, and Lila, Dr. Lila Mustafa is our in-house pharmacist, who's also going to be joining us today. This is a Q&A about diabetes and managing blood sugar. So even if you're not a diabetic, this PowerPoint presentation may still be helpful. So let's get started. So, Amanda, what does blood sugar even mean?
So your blood sugar is the most simplistic form of glucose or sugar. We're going to use those terms synonymously during the presentation in the body. So sugar or glucose comes from carbohydrates. So that's like your fruits, vegetables, whole grains, beans, legumes, and refined carbs that we'll get more into down the road in the presentation. Also, it's your main source of energy to run, walk, think, breathe, you name it. Glucose is what keeps us going. So although sugar tends to get demonized in our culture, it's really not the devil, and we do need it. Your brain runs off glucose. Also fats though too. Diabetes is a condition, though, in which your blood sugar levels are abnormally high due to not having enough insulin in the body or having insulin resistance, which we'll get to later. Something to note, though, before we get further into this presentation, guys, is this is more of a Q&A panel to go off of the presentation that we did in November last year. So if you're finding that we're answering things, more superficially here, and you want some more questions answered in depth, you can always refer to that video or do a one-on-one counseling with us, whether in person or virtual.
Yes, and it's YouTube link is here and it's on our website, which will be at the end. All right,
Absolutely.
so let me just see how I can advance the slides here. What did I do? Hang on.
Okay, while Katie's advancing, you could also see in that image above where it says glucose level with those three circles, those disc-looking red objects are meant to be like your platelets. The white crystalline-looking pieces in there are meant to be the sugar. So you could see hyper, you're going to have more sugar, right? Normal, of course, an average amount. Hypo, meaning low. And we'll get to what those specific numbers are down the road.
Okay. Are you guys still seeing my screen?
Absolutely.
Okay, great. And Amanda, can you tell us more too about what the blood sugar should be? Because we do this test at your annual physical. So it
Mhm.
would be helpful to know kind of how in range or out of range, we might be.
Yes. So when you log on to your patient portal after your visit, within about 24 to 48 hours, you're going to get your results. If you are fasting for your monitoring visit, which means no food, no carbohydrates, right, before that visit, your blood sugars fasting within normal limits reading would be less than 100. For pre-diabetes, it would be between about 100 and 126. A diabetic would be above about 126 and above. To get properly diagnosed, though, if you are
We're not there
having a
yet.
high blood sugar reading, we'll get to it. You want to also look at your hemoglobin A1C, which we'll get to.
Mhm. And why don't we find out about where's my slide go about what is an A1C?
I think it's down the road.
Okay.
Yeah. So,
So I
Katie,
want to go
how
through
would you
that.
define, you want to jump to that one
Yeah,
or?
because I think it's important to know if we're talking
Absolutely.
about it. So I can describe this a little bit because we're going to be mentioning A1C a lot. So, the A1C test is also known as the hemoglobin A1C, and it's a simple blood test that measures, it's actually an average of your blood sugars over the past 3 months. And a higher A1C is linked to diabetic complications. And when sugars enter your bloodstream, basically it attaches to hemoglobin, which is a protein. And everyone has a little bit of sugar attached to hemoglobin, but someone with a higher A1C will have higher blood sugars attached. And it basically measures the percentage of those red blood cells. So when you go to your doctor and you get that every 3 month test, it's likely the A1C. And we always recommend getting that if you do end up, having your annual physical and your blood sugar maybe is 115, 120, 130. You can then take that.
Even a 101.
hmm Yeah, it's always good to see if you've been trending above 100, to take that to your primary care and ask for an A1C. So I'm going to jump back now. Sorry, we kind of jumped ahead there, but that will help us to understand if we are indeed pre-diabetic or diabetic. Lila, do you want to tell us a little bit about what prediabetes means? You're on mute.
Oh no, Lila.
Can
There
you
we
hear
Oh, there
me?
we go.
go.
hmm
Okay, yeah, sure. So prediabetes is a condition in which your blood sugar is level is more than normal, but not quite at the level of type 2 diabetes. So 1 to 3 American adults have prediabetes, and 84% of them don't even know that they have it. Children and adults with prediabetes are more likely to acquire type 2 diabetes if they don't make lifestyle adjustments. And when you have pre-diabetes, your blood body cells are not responding to insulin properly. To get the cells to respond, your pancreas produces more insulin. When your pancreas can't keep up, your blood sugar levels rise, setting the stage for pre-diabetes.
Um, and it can be diagnosed with a couple of different tests. So the test that we do in clinic is this fasting blood plasma glucose. But you can ask your doctor for an A1C. So that 5.7 to 6.4 is considered pre-diabetes. And if you even have diabetes, and you're in this range, you're technically no longer a type 2 diabetic, you're pre-diabetic back, but so that's a good range to be in. But so it's diagnosed via two of these three tests. So you can't just get a plasma glucose and assume you have pre-diabetes. You need further testing, right?
It's something important to really hone in on of fasting glucose, right? Fasting plasma glucose versus your A1C. Your fasting plasma glucose is just a pinpoint in time of what that blood sugar is at that one moment that you happen to get pricked, where that A1C is a much more definitive lab test. That's why if someone has a high fasting blood glucose, it'll be confirmed with an A1C because there is, you could have a moment where you're a little elevated because you had something to eat maybe, or, maybe you're stressed, maybe you're sick. We want to know if you're consistently going high.
Mhm. And so what are some of the symptoms if you do have diabetes or pre-diabetes?
So if
Mhm.
Oh, sorry. So
Oh,
if
go
you
ahead.
do have pre-diabetes or diabetes, like Lila was saying, the body is of not absorbing the glucose or the sugar into the body. So the person might have excessive thirst because your body, if it's not getting enough, doesn't care if you're getting it from food or beverage. So the thirst will also help to flush the excess sugar out of the body. So the person will be urinating a lot to get rid of that sugar. They might be extremely hungry because they're not getting in that fuel. Because the sugar is running high, it can go affecting the kidneys, the eyes, the nerves. So you can get also that tingling feeling in your hands and feet, and the extremities in general. If the sugar is running high, blurred vision because it's now getting into the blood vessels of the eye, headaches due to that high sugar because your blood travels all throughout your brain, and then therefore fatigue because you're not absorbing the energy to properly metabolize it and utilize it to make ATP, which makes us go.
Great synopsis.
Got you.
And what is a symptom of possible hypoglycemia? I can jump in and answer this one because I honestly I think I've been here before. So, you might start to feel shaky, dizzy. You might even start to feel that blurry vision. So it's funny because some symptoms of hyperglycemia, this uncontrolled blood sugar, can actually be just an episode of hypoglycemia. And if you are diagnosed with diabetes, this is something to be very careful of because while you're experimenting with changes in medications or dosages, you could potentially I have a patient that he was taking a lot of diabetes medications at a high dose for his body weight. He lost 50 pounds. He was still taking the same dose and he was then going low blood sugar, which is dangerous. And if you ever find yourself in a hypoglycemia state, it's not on this slide. Actually, it is. It's called the 15-15 rule. And we'll get into what 15 grams of carbs mean. But basically, you want to take about 15 grams of carbs every 15 minutes and check your sugar until it goes back up to above 70. And then, you'll start to feel better. But definitely be aware of that. And if you have diabetes, it is always good to have, some gummies or an orange juice just at home, just in case you get that really low feeling. You can then replenish yourself, and this shouldn't be happening often. If it is happening often, you need to have a discussion with your endocrinologist or your primary care physician on what's going on. So this was a great slide to add. Thank you, Lila, for adding
And
this question.
piggyback off of that, it's a good segue when you were saying if it does happen often, there are actually prescription medications that are used for emergency situations. That's an injectable form of sugar that if there's a child or somebody that needs immediate help because of their hypoglycemia. It's an injection that can be given to caregivers or school personnel or family members to help support the individual who frequently has these hypoglycemic episodes.
That's really
And
good to
Lila,
know.
that's faster than drinking OJ, of course, right?
Yeah.
There we go. Do we want to go back through this?
This is on type 2 and how it's diagnosed. So we didn't actually review this one yet. So similarly to the how you get diagnosed for prediabetes, it's the same 3 tests, but the numbers are different. So above 126 is a indicator that you could indeed have type 2 diabetes, and an A1C above 6.5. So that's that main number to be looking at for sure. So if you have this already, you have this, you probably do have diabetes. This one we don't really see as often. It's used normally for gestational diabetes when women who are pregnant, but it may still be offered during your exam.
We'll do this for someone, say like they accidentally had something to eat. It slipped their mind. It's their habit to have something to eat. If you tell your nurse during the visit, no harm, no foul, like, hey, I accidentally had something to eat, they'll mark it instead of as a fasting glucose as a postprandial. So it'll change the way it's interpreted.
Mm-hmm. Because that happens sometimes. You accidentally, have something, and then your doctor's concerned because your blood sugar is high. Meanwhile, you just had a bagel. So no worries. We won't get mad.
Yeah, just
And this
tell
may
us,
not
please.
apply to, you guys per se, but maybe family members and just have some knowledge of what to expect when you go to the doctor's office. But the guidelines recently changed to screen patients at the age of 35 for diabetes, as opposed to previously it was starting at the age of 45. So that just kind of goes to show how concerning that the diabetes is, especially in our population in the US, that they're starting to screen 10 years earlier than prior.
Wow. And so what is, and we don't need to go through this too fast, but Amanda, can you tell us just briefly what type 1 and type 2 diabetes and how they differ?
The glaring difference between the two is type 1 is more of an autoimmune condition, right? You used to hear juvenile diabetes as being type 1. Now juveniles can have type 2 as well, of course. But the main difference is that the body has attacked the cells along the pancreas and it is not creating insulin. Where with a type 2 at first onset, their body may be producing that insulin, but instead that insulin is not meeting up with the cell to unlock it and allow it to enter the cell. So it's not an insulin deficiency. It's more so like the locks in the cell have changed and it's not unlocking to allow it to enter the cell to be utilized as energy or stored.
Mm-hmm.
A type 2, however, though, if uncontrolled, can progress and cause the body to not be secreting the insulin. The pancreas can get quote unquote tired. And then that type 2 diabetic would potentially need to utilize insulin.
Right. So, um, I was gonna also say something, but now I can't remember. So it'll come back to me. Um, and that's actually leads into this great question of how this will affect our future, if uncontrolled. So when there was people were registering for this webinar, people had concerns about the side effects of uncontrolled blood sugar. And this isn't to be a scare tactic by any means, but it is important to know how, if we're not taking care of this now, how it could lead to, problems down the road. I just always share that example. My aunt, she was 71, uncontrolled diabetic for years. She ended up passing away of a stroke. She literally, one day she was here, one day she was not. And it was all due to her poor control of her diabetes long term. So it's very important to be, you guys are here and watching this, so you clearly care. But one person specifically had questions about the nephropathy part of the kidney and how it can be linked. And I do have some helpful links in the end of this webinar for each condition that's listed and ways to help manage it while managing your diabetes. But
Not to
Amanda,
scare you guys,
right.
but a way to easily kind of see it and understand it is remember that picture in the very beginning we had of the blood cell with the platelets and the little dots of sugar? You want to think of sugar as a small, like crystalline structure, right? Think of like a very tiny little piece of glass. And if that's circulating in excess in your bloodstream, your main transport system of your body, you want to think about how much blood goes through your eyes, your kidneys, etc., your brain. And if that little those heightened little crystalline particles are going through, let's talk about just cardiovascular disease. It can kind of scrape the blood vessel, which causes your body, your macrophages, your white blood cells to be on alert mode. Like your police officers of your bloodstream come in and they create like a patch for that. And that patch, becomes hardened. It's like a scab and causes atherosclerosis. So you don't want those little crystalline pieces in excess going through those parts of your body because that's what causes the damage.
Great way to describe it. Um, Lila, how is the specific treatment for diabetes determined?
So depending on if you've been diagnosed with type 1 or type 2 diabetes, your treatment options will differ. So it is important to work with your physician to determine the best treatment options for you. So for the purpose of this presentation, I'm just mostly going to focus on the treatments for type 2 diabetes. And the new guide does recommend a individualized approach from the moment that type 2 diabetes is diagnosed. So before, your treatment kind of was dependent on how high your A1C level was. And now that is no longer the case. So now it's determined on several different factors, one of them being your comorbid conditions or what other disease states or conditions that you have. Another factor is your cardiovascular risk factors. So what is your risk of having a cardiovascular event? And that might include if you have high cholesterol, if you're obese, if you have an inactive lifestyle, if you have high blood pressure, a smoker, or if you have a history of a cardiovascular event or a family history of heart disease. Cost and access to medication is a factor that would help determine your treatment as well. And then just individual treatment needs. So whether that means, are you someone who will be willing to inject themselves once a day? Are you someone who is afraid of needles? Um, are you afraid of weight gain? Is there a potential for drug interactions? Are you someone who's prone to having hypoglycemic events? So all these things kind of play into how your treatment is determined. That being said, there are certain risk factors or certain comorbid conditions where we would choose certain treatments over others. So prior to, metformin was kind of the gold standard for treatment. So everybody who had diabetes or pre-diabetes would always be put on metformin, which is an oral type 2 diabetic medication, which we'll get into. That's no longer the case. So there's a lot of other options now that could be initiated either before or at the same time as metformin.
That's really good to know that they're evolving with the, new research that's out there. And what I was going to say when I blanked, moving forward, everything we're talking about is focusing on type 2 diabetes, not type 1. So just so you know.
Lila, just when we were on that topic, someone had asked a question in the chat. Does insulin have more of a side effect than the pill form meds? If you want to answer that.
I guess it depends on what side effect we're talking about. So every medication is going to have its own specific side effects. As far as if we're talking about hypoglycemia, so that low blood sugar risk is definitely highest with insulin versus any oral medication. And then the variety of oral medications that are out there have different levels of hypoglycemic events or just, if it's stomach issues, nausea, vomiting, indigestion. Every type of medication has its own class of side effects that go with it.
Definitely. Did you want to add anything to this slide, or is it pretty self-explanatory?
No, I did want to add a couple things just to kind of point it out. So we were
Yeah.
talking about the different comorbidities, and so I just wanted to give you an idea of what is pointed out exactly as far as the risks and the certain specific medications that you would potentially be put on if you have these factors. So if you do have a high cardiovascular risk, you would definitely be put on anything. I just want to point out that first and foremost, lifestyle modification is the number one thing with treatment of type 2 diabetes. So changing your diet, increasing physical activity, that's at the forefront of all this. So doing that in combination with adding medication is going to improve your management of your diabetes. So as you can see, all these treatment approaches have that at the baseline of it. Metformin is still there as like the gold standard. However, we usually use metformin on top of some of these other more specific medications that are targeting these specific risk factors. So, for example, if you have high cardiovascular risk, you might be put on metformin in addition to a GLP-1 agonist, which is an example would be Trulicity, Victoza, Ozempic, and these are injectable type medications. Or you might be put on something called an SGLT2 inhibitor. An example would be Invokana or Jardiance, or you might be put on both. And this is because of the evidence shows that being put on these particular classes of medications improves your or decreases your cardiovascular risk. Same thing with heart failure, chronic kidney disease. Those are additional comorbidities where they specifically point out classes of medications that would be more beneficial to you as opposed to other classes of medications. Now, if you don't have any of these risk factors, pretty much everything is on the table. You would still do lifestyle modifications. Metformin would likely be the drug of choice unless there was some sort of significant kidney impairment. And then these two classes of medications, the GLP-1 agonists and the SGLT2 inhibitors, are still have a significant influence on your A1C level. And so that's why those are still the primary choices after metformin, just because they do have that significant reduction in A1C level. Or, of course, insulin is also one that would be most beneficial. So it really is just tailored to how high your A1C level is if you have no risk factors, and what your goal is, what the target goal range is that we need to get you to.
Yeah, and I don't know if we have any additional slides on potential side effects, but I know a lot of people are concerned about, metformin and certain, vitamin deficiencies. Those are all very unique to the person. And that's why, we're here for questions if you ever have them, either during your monitoring visit or for a separate nutrition consult to help you determine what, food and nutrition and lifestyle strategies can help with potential side effects. Because sometimes the medications are what they are. So we have to, think about it from that way, and always talking to your endocrinologist or the person who prescribes it to you and what your concerns are. You are just as much part of this plan as your doctors are.
And you
So,
can even ask your doctor, depending on the nutrient, if you can assess through blood work if you're deficient or not to get a true baseline. And we
mhm.
can also assess some nutrients aren't assessed through the blood and they're assessed through diet. So we can also look through that in your WTC nutrition counseling visits as well.
Yep. All right. So, okay, here we go. Great. Lila, do you want to go through this really quickly?
Yeah. So, just for the sake of time, I'm not going to go through all the different medication treatments just because we did
Yeah.
that in the prior session. But I just wanted to touch on a couple of the newer ones and the most common ones in case if anyone had questions. So, first and foremost is metformin, and how does it work? So, it's an oral medication that is used to treat type 2 diabetes. It lessens the amount of sugar that's in the that the body produces and absorbs, as it lowers the glucose production in the liver. Metformin also lowers the blood sugar by increasing the body's sensitivity to insulin. It also decreases the amount of glucose that our bodies absorb from foods that we eat. Um, so, as previously mentioned, it's still an oldie but a goodie. It's highly effective. It can reduce your A1C by 1 to 2%. It's inexpensive. It's taken orally, and it doesn't cause weight gain, which is a good thing. It does, however, have its fair share of side effects, specifically GI side effects, so nausea, vomiting, upset stomach, gas, bloating. That is pretty common among this medication. Things that can help to reduce that is taking it with food. So that's important. If you are taking it once a day, you want to take it with your largest meal of the day. If you're taking it multiple times a day, you always want to take it with a meal. If you are still experiencing these side effects, there is an extended release formulation. It's metformin ER, and that helps to reduce the side effects. It just means it's once daily that you take it. So it's a once daily dose that you would take with your evening meal or the largest meal of the day. And that will help to subside some of these gastrointestinal intestinal side effects that you might experience. One thing that's important to note is that once you are placed on metformin, you pretty much should be continuing on it for as long as you can tolerate it, unless it becomes contraindicated for some other reason. But you would stay on metformin because it does have the most significant benefit compared to all the other treatment options out there. And then we would just add on therapy as needed to the metformin.
And it can sometimes make weight loss easier. I have had a lot of patients who were that pre-diabetic, insulin resistant, and they finally, just committed to a medication plus lifestyle plan. And it's sometimes you're fighting an uphill battle. So metformin can be a great first step, to getting your weight and thus your A1C in a better place to feel better. So, and then,
Lila, oh, sorry.
oh,
Mhm.
Question for you. Some of my patients want to try to take, it's a common question. They want to try to take Imodium with their long-acting or extended release, excuse me, metformin. What's your thoughts on that?
Yeah, so I don't typically recommend taking
Yeah.
Imodium with any medication for side effect control. Imodium is really something that's used like intermittently for, non-side effect related diarrhea, I guess I would say. And it is something that can mask a viral infection. So it's not something that we would recommend for side effects of metformin for sure. It's more just taking it with a meal, making sure that your provider or your prescriber knows that you're having these side effects and maybe considering using the extended release formulation. It, also making sure that you're slowly titrating up. So if you are going to be put on metformin 1,000 milligrams right away, you want to make sure that you start out with 500 milligrams, take it for a week, and then slowly increase to the 1,000 milligrams, as opposed to just starting right off of 1,000 milligrams right off the bat, so that it kind of subsides over time. That's what usually happens, is these side effects do subside over time.
It's extremely helpful, Lila. Thank you.
can you explain briefly what the GLP-1 and agonists are?
Yes. So the GLP-1 agonists are those injectable medications, and they could be injected once a day or once a week. It's your Ozempic, the Trulicity, um, the the Victoza. So any of those might sound familiar to you. And then it. I have the explanations on how they work, but they're also very highly effective. And one of the benefits of these class of medications is that they do promote weight loss. And as previously mentioned, they do have a positive there's positive data to support that they do have decreased risk of cardiovascular effects and just protect your kidneys as well. And this also has pretty significant intolerability as far as the GI side effects. So nausea, vomiting, and diarrhea are pretty common amongst this medication. And just some ways that you can subside that is eating smaller, more frequent meals, avoiding high fat foods, eating more slowly so that you can listen to your body, know that it's when it's full, and then also staying hydrated. So that's pretty common among this class of medications. I should say it is an injection that is given subcutaneously, so directly under the skin, and it does require pen needles for each injection.
And what is the deal with this Manjaro? This is like the hot button, medication I feel like out there right now.
Yeah, so Manjaro is the newest in its class. It's actually unique. It's its own class basically. It has two kind of mechanisms of action, and it has that GLP-1 agonist portion of it where it does promote that satiety and slow digestion. So it reduces your appetite. It also increases insulin sensitivity. It is highly effective. Where there we're able to see up to a 2.4% reduction in A1C. And another benefit of this medication is a significant amount of weight loss that was seen, as opposed to the class of GLP-1 agonists by themselves. So in this trial, they saw people have up to a 25-pound drop in weight.
Wow.
So that's pretty significant. And
That's
this also is an injectable medication. It is given once a week. Similar side effects in that it does cause nausea, vomiting, and diarrhea. It does decrease your appetite. It also can increase your heart rate. Just some cautions with this medication is that has the potential to cause gallbladder disease, pancreatitis, and also worsen retinopathy if you already have pre-existing retinopathy. Um, this is this was just approved in May of 2022, and it's only approved for type 2 diabetes at the moment. And then similarly, it is to help subside these GI side effects. You'd want to eat smaller.
Smaller meals.
Oh,
You
Lila,
cut
I
out.
think.
Your sound isn't working anymore.
Oh, check and see if the headphone disconnected. Mine does that sometimes. Or you press like mute by accident.
How about now?
Yeah, you're
There we
good
go.
now.
Okay.
I accidentally pressed what? It's like this little button here. Always
Yeah.
happens. Yep.
Yes. So eating smaller meals.
And I will say too, I know we're running low on time here and we still have a lot more to go. There's some people using this just for weight loss without diabetes. We're just focusing on it for diabetes treatment, and has to be prescribed, and all of these medications have to be prescribed by your endocrinologist or primary care physician. Not covered. None of these are covered by the WTC program. We can help you, with taking them and whatnot, but we are not the prescribers.
And that kind of segues to a question that we got in the chat. Is hypoglycemia diabetes? It's not necessarily diabetes. It could be a sign or symptom of diabetes. Hypoglycemia just means that the blood sugar is running low, under 80 milligrams per deciliter, if you're looking at like a fasting blood glucose.
Mm-hmm.
So if someone is
Yeah.
taking like this medication and they don't have issues with, they don't have high blood sugars, and they're taking a blood sugar lowering agent for weight loss, it could cause them to go hypoglycemic, which could
This
cause a slew of other issues
just
like we went
happened
over.
to my patient's wife today.
Lord.
He was telling me, so just be very careful. All right.
Yeah.
And then just for safety purposes, how do I use those injectables if someone is injecting, Lila?
Yeah, so I don't have to go through this really. This is more for your reference. I wanted to make sure
Yeah.
that those who are on particular medications just know what is the proper way to inject it. And I did include a video that you can kind of reference on the proper injection technique of these non-insulin type medications. So that's the ones we just talked about. So the GLP-1 agonist, the Manjaro, they all have their own unique instructions. So you do have to reference the manufacturer labeling for specific instructions, but these are just some general guidelines to remember. So if you are injecting subcutaneously, that's in the fatty area of under the skin. So those are areas that you're going to inject are either in the abdomen, the thigh, or the upper arm. You do want to make sure you rotate the injection sites at least once a week. If you're injecting multiple medications, you don't want to inject into the same area. And you do have to, most of these medications require you to use what's called a pen needle. So the medication is in this device that's a pen, and you have to screw on these needles onto the device. And you should be using a new needle every single time. So never reuse a needle. Change the needle with each administration, and make sure you're discarding of these needles into a sharps container of some sort to dispose of it properly. Same thing with the with the insulin medications. Uh, just some general guidelines to follow and some videos that you can reference as well. And then how to properly store your medications. I just have a slide on that as well. So oral medications, the most important thing to remember is to make sure it's stored at room temperature in a cool, dry place away from moisture. So someplace like a kitchen where there might be some steam and like cooking going on might not be the best place for medications that are tablets or capsules. Definitely the bathroom cabinet. It is the worst place for medications because of the humidity in the bathroom. So just things to keep in mind. For injectables, both insulin and non-insulin, the guidelines are here, but basically, you need to store these medications in the refrigerator when they're not when they haven't been opened yet. And then once they are opened and after the first initial use, you can usually store them either refrigerated or non-refrigerated for a certain amount of time, and that's manufacturer specific. So it could be for 28 days once it's opened, it could be for 60 days after it's opened. It really just depends on the product itself. So just ask your pharmacist about any specific storage instructions or refer to the manufacturer instructions as well.
And if anyone came late, this video is being recorded. And then please send me an email if you would like a PDF of the slides, because we do like Lila put really helpful links in here that are all embedded throughout the presentation. So let me know if you would like to receive it, because then that way you have access to all this extra material that we're not going through today.
You
And just Yeah.
Sorry. You could just simply reply to your invite email. That's Katie's
Yeah.
email address.
Yep. Catherine Hughes. And then lastly, what can we do to reduce the risk of complications? Obviously, monitoring your blood sugar is very important. Also paying attention to your blood pressure. That's extremely important. Looking at cholesterol, those are side effects of this diabetes that can be going on. Same thing with your kidney function. We do a full, urine analysis. We do blood work here at your, yearly routine monitoring visit, but it's also always good to be following specifically with a nephrologist or an endocrinologist, getting your feet examined, getting your eyes checked, keeping up with your vaccines. It's flu shot season, it's COVID booster season, pneumonia, making sure you're always taking your meds as prescribed. And lastly, like we had said before, make sure you're sharing your beliefs and concerns with your prescriber. We're here to work, as a team together, right, guys?
The concept of be thy own doctor, not saying delegation of responsibility or anything like that, but more so taking an active role in your medical care and understanding what your lab values mean and taking ownership of what needs to get done. Because like that statistic we showed in the beginning of the presentation, what is it, about 84% of people with prediabetes don't know they have prediabetes. So really looking at your lab work, asking questions, being actively involved is so incredibly important, because not always is everybody talking to each other. Maybe you see a doctor at Northwell, someone at Stony Brook, someone at NYU, and not everyone has access to all the same stuff. And sometimes things get assumed, not, rightfully so, but you want to just make sure you're paying close attention to what's going on as well.
Exactly.
I just
And
wanted to
honest,
touch,
yeah.
I'm sorry, I just wanted to touch base on that question that was brought up about, how do I prevent, further kidney complications or any diabetic complications for that matter. And it is a multifactorial approach. So patients who have diabetes usually have to manage their blood pressure, their blood sugars, their cholesterol, all these things as well in order to be most successful and prevent any complications. So your kidneys, from having high blood sugar from diabetes, it can damage the blood vessels in the kidneys, and then as well as having high blood pressure will do the same thing as well. So really, it's just really important that you make sure that you have a healthy lifestyle, but also take the medications as prescribed. And if there are any concerns about your medications, that you bring it up to your, providers so that they are aware, because these things are all meant to work synergistically to help you better manage your diabetes. And early detection and initiation is going to have the best outcomes. But if you don't tell us that you're not taking your medications or you're having side effects of medications and you're just not taking them, you're really not benefiting anybody except you're not benefiting yourself for sure. So just keep that in mind.
And we're never going to beat you up. Just tell us the truth. The more we know, the more we can help. Like some members come in and be like, "Oh, Amanda, don't beat me up. I was doing this." I'm like, "I'm never going to beat you up."
We're all
It's
here to
always
help.
empathy and love. And we know no one's, perfect. And also we know that this is confusing. So we're here to help.
This beginning of this presentation could honestly be it, but we do actually have more to go. So I want to keep going. We're going to get more into the nutritional piece now on, looking at carbohydrates, diabetes, but we do have a whole longer video on more in-depth carb counting, label reading, all these things from last year's video on the site that's also linked here. So just
Plus,
FYI.
check out the whole slew of the other videos, because a lot of this stuff is the same across the
Yeah.
board for weight
Yeah.
loss, for general healthy eating.
Yep.
Dive in.
Amanda, real quick, what foods have carbs?
What foods have carbs? So, as you can see here from the Bullseye Food Guide, your grains and starches have carbs, your fruits and vegetables have carbs. So, that's why carbs are not the devil, right? Also, some proteins have carbs in them as well. And of course, your milk and yogurts have carbs. So, when people tell me I cut out carbs, I often am just like, really? How are you alive?
And
And is
not
that a
to
long-term solution?
not to confuse, because I actually made this slide. Only beans and lentils really have carbs, tofu a little, but most proteins
Very
don't really
minimal.
have. So that was kind of a typo on my end, but it is technically true.
It's more like when you think of your carbs, think fruits, vegetables, whole grains, beans and legumes, and maybe you'll get very little bits from like nuts and seeds.
But really, the only foods that have little to no carbs is the fat category and most protein categories. That's why we always want you to pair protein with a carb, so you feel more full and control that sugar. But again, not for today's topic. Um, and just so you know, when we say serving of carbohydrates, what does that mean? In general, rule of thumb, 15 grams is 1 serving. So 30 grams is 2 servings. 45 grams is 3 servings.
And a serving isn't necessarily a portion size.
Right. So Amanda, like, what if the food doesn't have a label? Because we're gonna go into label reading in a minute, but what do we do if we don't really know?
There's a couple of things you can do. We all have smartphones. There's the diabetic exchange list, which has everything for the most part, most carbohydrate groups in intervals of 15 grams of carbs. So if you're looking at the diabetic exchange list, it'll have it listed as like grains or starches, fruits or vegetables, and what each interval would be. But also you can look at MyFitnessPal, Fujikate, different apps out there and type in the information and it will spit back up the nutrition facts label for you. Or even looking at, you can Google, and please, you don't want to Google most information. So say no, with a big asterisk there. Say you Google, nutrition facts of a banana. You can see in the nutrition facts label that shows up on the side of the screen the source that it's pulling from. If the source says USDA, that's one of the best possible sources that you can get your information from regarding nutrition facts. That's what a lot of those databases utilize anyway.
hmm And just for rule of thumb, like a medium-sized piece of fruit is about a serving of carb, aka 15 grams, a half a cup of any starchy vegetable like potatoes, peas, corn, a third cup of any rice or pasta, half of a banana, half of a large banana or one small, and a 1/4 of a bagel. So just
It doesn't
FYI.
necessarily mean like that's laughable. I would not eat a third of a cup of brown rice. I eat like a cup of brown rice, right? So it's just a way to kind of think about it as saying, okay, in terms of numbers, I know in a snack I could have 15 to 30 grams of carbs, right? 1 to 2 servings. Or in a meal, I could have
Sorry.
45 to 65 grams of carbs. So that's about 3 to 5 servings of those like portioned groups. So it's really just an interval or like a unit to think of when measuring food. This is
Mhm.
a topic that gets kind of hairy. So if you're really interested in this is where we would calculate your individual needs for you in a nutrition counseling visit and tell
Mhm.
you how many servings or grams of carbs that you need in a day or in a meal and a snack, etc.
Yeah. So, for example, like, do you have to follow a low carb diet if you have diabetes? I would say technically yes. You definitely want to be monitoring your intake, but how much that means is different for everyone. An example is if you're eating a 2,000 calorie a day diet, you want approximately a low carb would be considered about 40% carb. That's still a decent amount. That's almost 200 grams for the whole day. So it's not keto, it's not Atkins, it's just being smarter about your carbs. And that's where our previous literature all over our website has information on this. And if you've ever been in a nutrition counseling session with Amanda and I, we love our carbs and we love you to eat the healthy carbs. We just got to be more smart about it. Instead of no carb, it's more like just lower and just being smarter with it, higher fiber.
You guys
Um,
remember that like where's the beef lady from like the 80s? We always like talk about it in our appointments. Like think of like that where's the beef lady? Like where's the protein? Because you want
hmm
to slow down digestion. So it's not always necessarily low carb, it's low glycemic index. So
hmm
what's the likelihood that that carb is going to spike your blood sugar? So the more fiber, the more protein, healthy fat will slow down digestion so it's less likely to spike your sugars. So that cliche saying of like everything in balance or everything in moderation is true in that like when you're having your plate, you want to have about a palm size of protein, about a cup of a starch. That's not always
Okay.
necessarily needed, and some vegetables.
Thank you.
Yeah.
Um, and what should we be looking for on the nutrition label? I'm so glad you asked. Um, I want you to always start with serving size, right? Are you eating one cookie, two cookie, three cookie, or the whole box? That is important because that will also tell us, a valuable information. So always start with serving size. And if we're, looking at total carbs, a really common question I ask are is this total carb in addition to the total sugar, or how does that work? This is the amount of carbs that are in the food. This total sugar is included in this 23 gram of carbs. So that it's not in addition to. So if you're saying, if we know 15 grams of carb is a serving, and for snacks, like Amanda had mentioned, around 30 grams is a good, number to shoot for snack limit. we know that this food has about 23-ish grams of total carb. If we want to, which is under 30. If we want to be even more, looking at this from a nutritional perspective, technically the net carbs of this is 21 because fiber takes away the carbs that we absorb. We don't absorb fiber in the form
It
of blood
passes from
sugar.
end to end. You don't absorb
Yeah.
fiber.
So technically this food has 21 grams of total carb. I don't want to confuse anyone, but just know the more fiber the better, because that means there's less carbs your body's actually got to work through and digest. Um, Now total sugar and added sugar are very important for diabetics. It says for everyone, the American Heart Association recommends less than 36 grams a day of added sugar and 25 grams for women. But I think for diabetes across the board, the less is best. Single digits when we're looking for added sugar here. Um, but added sugar is not in addition to total sugar. This product has 12 grams of total sugar. All of them were added. If this had said maybe 10 grams, that means there's two total. No, it's this, there's 12 grams of added sugar, and whatever this product is had no natural sugar. Think of an apple. An apple's all natural sugar. Apple pie, you're going to have that natural sugar from the apple. Then you're also going to have the added sugar from, the baking of it with, molasses and all that stuff. And this product wouldn't be a great snack just because it also has very little fiber, or excuse me, yeah, it has very little fiber, very little protein. So this might not be a dietitian approved snack, but maybe pairing these cookies with maybe some protein might be helpful. Or eat your meal first, then have maybe a cookie, 1, 2, or 3 to feel satisfied. But the number of choices again is going to be very dependent on the person. Amanda, do you want to add anything to this?
Just in terms of added sugar and total sugars, you just want to think of fruit. This is a really common question we get: is fruit the devil? Fruit, you want to try to have about 2 to 3 servings a day, depending on the individual. But still, when you have that fruit, because of that natural sugar that's in it, it has fiber, like Katie was saying, that helps to mitigate the blood sugar spike. But you also want to consider pairing that with a protein or healthy fat. So 2 clementines, low-fat cheese stick, apple peanut butter, for example.
And how many carbs should I eat in a day, and when is it best to eat carbs?
So you want me to answer? Or do you want to answer?
Yeah, go for it.
So how many carbs you should eat in a day is very dependent on you as an individual, especially your activity factor, how active you are. Typically, about every hour of activity, depending on how vigorous, you need at least 15 grams of carbs to replenish. But on average, if you're thinking of it as 15 to 30 grams per snack, about 30 grams at breakfast, and about 45 to 65 grams of carbs at lunch or dinner is a good rule of thumb. Or you can think of simply that USDA My Plate. You do 1/4 a palm of protein, about a cup or a fist of starch is the other fourth, and then 1/2 being, maybe a side salad to start your meal, and then maybe a side of veggies during your meal, because that will add fiber to mitigate your blood sugar spike, but most importantly, make you feel full so that you're not meandering going for, some sugar or other sources of carbs in lieu of not having enough of the quote unquote good or better carbs like fruits, vegetables, whole grains, beans, and legumes. Because if you don't get enough of the good stuff in, that's probably where that common question of why am I nighttime eating ensues from. It also has to do with meal timing as well.
Yeah, and I heard this tip the other day, and it's eat what you want, add what you need, right? You don't need to be restricting yourself of your favorite, type of bread or your pasta or whatever, but make sure you're eating what you like, but being mindful, and add what you need. Add your protein, add your fiber, add your exercise, add your water, so you can balance it out, because we want this to be a lifelong, journey and a lifestyle. Um, an example of a healthy diabetic breakfast is here as well. You got your toast that you like. You got your eggs for protein. Again, no carbs there in eggs. A little bit of olive oil for the cooking, no carbs there. And then a piece of fruit just to add that extra 15 grams of carbs in, that vitamin C, that fiber. We love it. Eggs are great for you if you have diabetes, just FYI.
Absolutely.
And lastly, I just wanted to throw in some resources that you can use to learn more if you're really passionate about this topic, or you're finding this, information helpful today. We are a plethora of resources, Lila, myself, and the whole WTC team, as well as, other areas on the internet. Go to our website. Our website is fantastic. I want to just pull it up now. Because it has all of our videos from every month that we've been doing this for almost 2 years now. If you scroll down, we have all our pharmacy benefit information, information about our flu shot, information about your Express Scripts, prescriptions, our yearly calendar. We're going to do a whole new year next year on all different topics. You can access our nutrition website here with all of our nutrition information, handouts. There's a whole diabetes link. And then
And a
all of our
course. There's a
videos.
whole 3-month course that if you're
Yeah.
like, oh, I'm a little about doing counseling, we get it. All right, not everyone's ready for counseling. But if you want to follow along, the course is under construction, but it's all there. Just because we're moving around different weeks, we're being a little nitpicky about some stuff. You can follow it along week to week, like a Blackboard course,
Yeah.
and you get a video, an
Yep.
announcement for the week, and handouts.
And there's a blood sugar management tab with all of our handouts. And we didn't even touch upon our artificial sweeteners today and sugar, desserts, label reading, in depth, pasta. It's all here. It's all free. It's all for you. We do it for you. So just so you know. And then some other information. I just have to get back to the PowerPoint real quick. Um, is the let's see, updated DM webinar is the oh, sorry. I got to slip to the last slide now. But other website information that Lila had put on disposing of needles. I put the American Diabetes Association also has. Whoa, we're getting a little crazy. Hang on.
Something to note too, that if you just have a simple one-off question, there's no obligation to book a nutrition counseling appointment. We're here. Our door's always open. You could call us, you can email us, you can ask the question during your monitoring visit, whatnot. We're here to help.
Yeah. So yeah, lastly, oh my God, I'm having some
Oh
tech
no.
struggles today, guys. Just you can see here, we threw our website on here, diabetes.org. Like I said, has great information on each of those disease states, the kidneys, the heart health, is specifically for diabetics, which is, I think, fantastic. And then you can always call and schedule a one-on-one. And then does anyone else have any new questions for us? Now is your time. We have about 5 minutes left. If you want to unmute, put it in the chat or message us privately. Again, if you would like to receive the slides, please send me an email back.
Ladies, this is Terry Meany.
Hi.
Hey, Terry.
Thank you so much. You guys are always so informative, and
Aw,
it's tremendous. I get
thank you.
so much more from you than I do from my endocrinologist, so it's
Mm,
really
Oh,
helpful.
thank you. That's what we
I
really
did
try.
I did have one question.
mhm.
I have type 2. I've had it about, I guess I'm going on 3 years now, diagnosed with. And I was wondering, I'm supposed to stay between 70 and 180. Is it better to keep it as low as possible? Is that helping? Would I be helping myself even more? Or just stay between 70 and 180 because it doesn't matter?
It depends on when you're taking your blood sugar, whether it's fasting or postprandial. But fasting, the closer you can get to 80 to 100 would be the winning answer, or less than 140 if it's like postprandial, which is like after, 2 hours or so after you ate. So it really depends on the timing of the food. But
I
overall, as low as you can go is typically the answer.
Yeah,
Oh,
and
okay.
there is such thing as at the extremes, right? We don't want you hovering above that 180 mark, but it's also if you're never above 70, that's also not good. You're probably going to
Yeah.
have symptoms of fatigue, lethargy, etc. So I would say I think that range you're trying to stay in is good, but anywhere in the middle of that range is also good. We never want to be on each end of the highs or
Oh,
lows,
okay.
you
Yes,
know?
absolutely.
Because if you're a
Yeah.
Absolutely.
diabetic, you want to try to be in pre-diabetic ranges. If you're a pre-diabetic, you want to try to be within normal limits ranges.
Oh, okay.
That's a good tip, Amanda.
But I wouldn't try to shoot for, less than 70 or 80 just because
Absolutely.
that's
No.
when you're going to start feeling those hypoglycemic effects and you don't want to feel crappy either.
Right.
Yes, yes,
Like I know my fasting
absolutely.
sugar is like 91. So it's like I think 70 I'd be like dead. So everyone's different though. But yeah, keep an eye on it though. Good job.
Thank you so much. Thank you for everything.
Of course.
Thank
Any
you.
other questions today, guys? Sounds like we were pretty comprehensive. I wanted to thank Amanda and Lila for helping us out today, myself. We hope you enjoyed it, and thank you all for being here. We wouldn't have our program without you. So keep supporting us, keep supporting yourselves. We're all in this together, right?
Excellent presentation.
Thank you.
Thank you.
Thank you.
Be well,
Okay,
all.
thank you very much.
Thank you. You too.
Yep.
Thank you.
Thank you very much for the presentation.
You're so welcome.
Thank
Take
you.
care.
Bye.